For HPV vaccination, you can see the recommendations here. And again, that is something that hopefully the clinics are taking care of and recommending so that all of the young people are up to date on their HPV vaccination. And then cervical cancer screening guidelines for women. Basically, the age of 21 is when the pap smears will be done annually, but they will start earlier if the woman is sexually active. If the pap is negative, then they have now gone to, instead of an every year, which was for many, many years, it was always every year, has gone to an every 3 if they have a clear pap. So again, there's always changes with recommendations, so you can always look them up to provide accurate information, but it is kind of holding pretty steady for most of them anyway, as to what we've been doing for quite some time. For colorectal cancer, we'll be running through this again in the GI unit, but they do, after the age of 50, want to have a fecal occult blood test annually, so that would just be a stool sample testing for blood that's not visible to the eye, and then they would want a sigmoidoscopy every 5 years and a full colonoscopy every 10 years. So they'll basically alternate between those two, in addition to, of course, having that stool sample every year annually for blood. And that starts at 50, but again, if there is a significant direct first-degree relative with colorectal cancer, they will start sooner. In the last several years, we have made some staggering headway on diagnosing of lung cancer earlier, which is remarkable. I know I've just been to some conferences where they've given statistics, and even at Essentia, what a great move they have made in the right direction. So now, if you have a current or former smoker, quit within the last 15 years, again, with at least a 30-pack year history, they're recommending this low-dose spiral CT scan. I know I've taken care of a patient himself that they would have never ever found this had he not done this. And he had quit smoking a while ago, but he had smoked for quite some time, and he was so grateful to have found the lung cancer at a time where it was treatable, surgically removed, and would have a good outcome versus, he wouldn't have felt sick or had symptoms for a long time, and then he would have been in the boat that a lot of people are when they're diagnosed with lung cancer and they don't have a good prognosis. So it sticks with me because I have a real face and a name and a person that was so appreciative and grateful of spreading the word of these low-dose CT scans, and he was very thankful that he was able to get that done. So again, this is a great move in the right direction for people. If patients aren't sure if they qualify, they should just certainly check with their physicians. We know tobacco smoking has a very significant increase in the risk of many types of cancers, obviously lung cancers. We also talked about it with pancreatic cancers, also with cancer of the esophagus, larynx, pharynx, oral cavity, any of that, and then also the genitourinary cancers, the kidney and bladder cancers. So those are some of the cancers, just to name a few, that are very directly related to cigarette smoking. So I just thought this was interesting. I was hoping to find one that was more like 2015 and newer. I'm sure it'll be coming, but to this date, you can see that we made a significant decline in cigarette smoking by gender, which is great to see. Like I said, I'll be anxious to see the latest statistics on this. Prostate cancer screening guidelines. After the age of 50, every year they would want a digital rectal examination when the patient is having their routine physical, and then also a PSA, which is a simple blood test that they can draw. So that is the recommendations for the prostate cancer screening. And again, a lot of people are on this screening. They notice and they watch that PSA, and this is where they are identifying that prostate cancer early. So hopefully people are getting to the doctors once a year after the age of 50 and getting the appropriate screening done that they need. This acronym CAUTION just goes through some of the warning signs of cancer, changes in bowel or bladder habits. Again, the change in bowel pattern from just like constipation to diarrhea or just kind of subtle changes is the earliest sign of colorectal cancer, for example. A sore that doesn't heal, unusual bleeding or discharge, of course any thickening or lump in the breast or elsewhere on the body. Also, if there is a lump, is it fixed? Usually if it's movable, that's a better sign, but if it really seems to be a firm fix, that's not as good. Indigestion or difficulty swallowing, unusual weight loss. Again, although weight loss and dysphagia are definitely later signs of those sorts of cancers, esophageal throat, larynx, etc. Obvious changes in warts or moles, and we'll be talking about all that specifically in the integumentary system. And then if they just kind of have a chronic cough or hoarse voice, again, sounds like a smoker's cough, but they don't smoke. This is something that we should investigate at minimum. Anything, listen to your body. If there's changes, get it checked out by a professional. Cancers are classified by the type of tissue from which they arise. We'll talk on the next slide specifically how they will document that. Solid tumors versus will be based on that specific tissue, breast tissue, lung cancer, etc. Hematological or blood cancers that we will be talking about will be leukemia, lymphoma, and myeloma. So again, there are different types of cancers, the solid tumors that we think about with breast and lung, and then the blood cancers, the three most common, leukemia, lymphoma, and myeloma. But we'll talk next on the next slide here about the specific classification. So for cancer tumor staging, you can see on this slide where they will write it according to the stage. They'll have a T, an N, and an M. T for tumor, N for node, and M for metastasis. So this is just the medical way. Again, the primary tumors are stage 0 to 4, the lymph nodes 0 to 3, and then metastasis, is either 0 or 1. So again, you don't have to memorize this. There are tables in your book that explain how that all works, but just that you understand, if you see a T, that's tumor. If you see an N, that means that there was nodes involved. In this case, we have T1, so the tumor, that's the lowest level of tumor, meaning it's limited to the origin, it's contained. N is 0, so that means there is no nodes involved, and M is 0, which is no metastasis. So even if just at this point in time, you understand that the T stands for tumor, the N for node, and the M for metastasis, and then you could understand that if there was a larger number behind that letter, that would be worse. I think that's the point at which we should be as nurse generalists, because we want to read H&Ps and understand what they're talking about. I would encourage you to take about 4 minutes. This is a short YouTube, but very, very good on discussing the effects of cancer in the body. And then cancer tumor grading. Cancer tumor grading is a grade 1 to a grade 4. Grade 1 is going to be the best. I mean, the most well differentiated, meaning it resembles more of the tissue of origin. That would be grade 1. And then grade 4 is the worst. That means that it is poorly differentiated. It looks very different. We can't even tell what kind of a cell it is. It doesn't look close to the tissue of origin. So grade 1 would be the best. Grade 4 is the worst if we're looking at the cancer tumor grading. Obviously, the more the more that it's well differentiated and looks more like its own, again, grade 1, the better the prognosis. Teaching regarding cancer risk reduction is super important. Even if your patient isn't here related to cancer treatment, we should be checking to see if they're up to date on their screening. Do they understand some of the basic cancer risk reduction things that they can do for themselves? All of these that are listed here would be an example of primary prevention. Remember the levels of prevention: primary, secondary, and tertiary. Primary is all related to health promotion. Again, you can take a look. We know that fruits and vegetables and fresh vegetables have high antioxidants: broccoli, cauliflower, Brussels sprouts, cabbage. We also know the fiber, whole grains, fruits and vegetables, and high in bran. Those are also very, very good. Excuse me. What happens there is that if we have a lot of fiber and healthy foods, we're eating less fats, we're eating less red meats. And also, as far as our GI tract, we'll talk about, it allows things to kind of keep going through at a regular transit time, which is also healthy for the GI tract and will decrease the chance of developing cancers. Increase intake of vitamin A, foods high in vitamin C, again, weight control, keeping at your ideal body weight, making sure that we're decreasing intake of animal fat and red meats. We know that there is more risk with nitrates and processed foods as well as smoked foods. Again, stopping smoking and minimizing alcohol consumption and avoiding overexposure to the sun or wearing sun protection when you're in the sun. Those are all really important primary prevention measures that we can educate our patients in the hospital, and certainly we can educate in our communities as well. Here are the 3 levels of prevention that we keep coming back to. Again, primary prevention is all of the health promotion, all of the teaching and counseling on healthy lifestyle, living, exercise, etc. A third of cancers could be prevented. So if we do enough primary prevention teaching, that's taking care of a third of cancer development. Secondary prevention is your early detection and screening. So this is all of the health education programs, all of the screening programs, all of the screening recommendations that we just talked about, and getting that out there and making sure people are getting identified and getting their cancer screened so that we can detect it early. And then tertiary prevention is just improving quality of life and minimizing the deterioration associated with the cancer. So this would be, you know, working through the cancer when you have it, and so just making the best of it as far as quality of life, functionality, emotional health, etc. Next, we will talk about 3 of the most common types of blood cancers or hematologic cancers. These are diseases and disorders of the white blood cell. Again, we'll talk about how the bone marrow impacts this, because of course the bone marrow is what's responsible for producing our white cells, our red blood cells, and our platelets. So leukemia, lymphoma, and myeloma. Leukemia is uncontrolled production of the immature white blood cells in the bone marrow. Lymphoma is a cancer that is looking more at the lymphocytes, the B and T cells, and myeloma is uncontrolled production of abnormal B cells in the bone marrow. So we'll be talking about each of these, and as far as the cases, 47% of blood cancers are lymphoma, and these are 2019 statistics, but 47% are lymphoma, 35% leukemia, and 18% myeloma. So again, that's why we're talking about these 3 specifically, just because of their numbers and the likelihood of being introduced to them. Leukemia and Lymphoma Society website is also very helpful, has tons and tons of information about blood cancers. Now, I realize that some of these slides get to be pretty detailed. I don't think you need to know every single detail about all of the various forms and types of leukemias, but they are typed differently. Leukemias from the lymphoid line versus leukemias from the myeloid line, but either way, that you could recognize ALL and CLL as acute lymphocytic or chronic lymphocytic leukemia, and then AML or CML, acute myelogenous leukemia or chronic. So you'll see these abbreviations, ALL, CLL, AML, and CML. So I wanted you to be familiar with these as the various forms of leukemia. We know that acute leukemia is more common in children and young adults, and we know that it can grow very, very fast. Chronic leukemia is a little more gradual onset with a slower course and more common in the age group 25 to 60. So again, there's differences in which types we would see at different age groups, which ones are a little faster growing, which ones are a little slower going. But the bottom line that I want you to understand is that there's an increased number of immature white blood cells, so increased number of blast cells. And those white blood cells, the total white blood cell can either be low, normal, or high, but if we actually differentiate and look at the number of mature versus immature, we will see an increased number of immature white blood cells. Again, patients with leukemia or any bone marrow alteration, again, this is a cancer of the bone marrow and the blood, will have usually a decrease in red blood cells as well, a decreased red blood cells, a decreased hemoglobin, so they might have weakness, fatigue, headaches, and they typically many times will have a decrease in platelets as well, so thrombocytopenia, which will manifest itself as be more frequent nosebleeds, bruising easier, increased menstrual flow, hematuria, blood in the stool, things like that. So looking for all of those things, decreased number of mature white blood cells, or increased number of immature, whichever way you want to look at it, decreased red blood cell production, and decreased platelet production. Because remember, all of those cells are made in the bone marrow. So that's the most important thing to hang on to with all of these blood cancers, because there are lots of details with each of them. But if I simplify it and know that there's a problem with the bone marrow and understand what that's going to do to the 3 different types of cells, white blood cells, red blood cells, and platelets, I can probably handle a lot of questions that come into these categories. So this does a nice job pictorially showing you the blood stem cells and how they're developing, and actually how we have excessive production of immature stem cells. Again, the white blood cells in the bone marrow stops normal production of red blood cells and platelets and mature white blood cells. So it's going to result in 3 different things: anemia, thrombocytopenia, and leukopenia. Those 3 things together we call pancytopenia. I don't know that we've talked about that word yet, but if you see pancytopenia, that means that they have low red blood cells, low white blood cells, and low platelets. Anemia, thrombocytopenia, and leukopenia equals pancytopenia. So that's one thing that I wanted to highlight on this slide. Again, then we can think, they're at risk for infection, they're at risk for bleeding, they're at risk for feeling weak and dizzy, falls. Again, all of the decreased oxygenation stuff with the low red blood cells and low hemoglobin, all of those things that we did cover in cardiac hematology, we can transfer here to this area on blood type cancers. Before we move on, I do want to reference your pediatric book for excellent tables and care plans for the blood cancers, leukemia, lymphoma, and myeloma, because these are can be more prevalent in that age group. They really have some more extensive information than Iggy has, so you'll definitely want to take a look at those care plans, because she does a really nice job of explaining them. As far as lymphoma, then, this is a cancer of the lymphocytes, and so we have Hodgkin's lymphoma and non-Hodgkin's lymphoma. And again, the difference is that the Hodgkin's has the Reed-Sternberg cells and the non-Hodgkin's does not. But does that really matter to the nurse? Does that matter to the nurse caring for the patient? Not so much, but it is of interest, and you can see the owl, what looks like owl eyes in that picture, and that's what the Reed-Sternberg cell will look like under the microscope. So I don't care that you differentiate between the 2 different types, but I do want you to understand that lymphoma is a cancer of the lymphocytes. They begin to multiply more rapidly than normal. And again, most common assessment for any lymphoma is large but painless lymph nodes. That's a very, very common symptom. Other symptoms: drenching night sweats, weight loss, fevers. Those can be some other things, but large painless lymph nodes without any reason for having those large lymph nodes. That's an overactive lymphocyte production that's causing that. Multiple myeloma is where we have abnormal B cells called myeloma cells, and they collect in the bone marrow. So these malignant cells grow and destroy the normal bone tissue in the bone marrow. So there's overproduction of this abnormal antibody called a monoclonal or M protein, but either way, we don't need to know all those details, but we do need to understand that this is malignant abnormal cells that grow and destroy the normal bone tissue and affect the bone marrow. So that last bullet looks at, other stem cells in the bone marrow become crowded, again results in anemia, risk for infection, risk for bleeding. Bottom line, they're going to have decreased red blood cell, decreased white blood cells, and decreased platelet. Again, pancytopenia looks very similar to what we discussed with leukemia. The other thing that's different with multiple myeloma, as you can see though, is they're more prone to bone fractures. Because of the bone destruction, the calcium leaves the bone, right? And so we end up with increased blood calcium. Hypercalcemia is a defining kind of characteristic that is different for multiple myeloma than you would see for other things. Because of the bone marrow destruction, that calcium leaves the bone and therefore will be higher in the blood. Other than that, the patient may have no symptoms at time of diagnosis, or if they do have symptoms, they might just have some bone pain, some low back pain. They might be at risk for more fractures and that bone pain due to the hypercalcemia and that demineralization of the calcium from the bone. Otherwise, they kind of have some of those signs and symptoms of anemia, fatigue, and pallor, and what you would see normally with a low red blood cell or a low hemoglobin level. I do like how this slide puts them all side by side. Again, leukemia is a cancer of the bone marrow and the blood. Lymphoma is a cancer that originates more in the lymph and then can, of course, travel. And myeloma is a cancer of the plasma cells, but that then is found primarily in the bone marrow and destroys the bone and the bone marrow. So either way, you can kind of see some similarities and then you can see some differences, but especially with leukemia and lymphoma, you'll see a lot of the same systematic weight loss, fever, night sweats, things like that. You'll see some of the similarities of a low red blood cell or low hemoglobin where they might have dizziness, weakness, short of breath, etc. And muscular weakness, again, less oxygen getting to the muscle. You see differences, especially with the multiple myeloma, where that's where you have the hypercalcemia and bone demineralization, chance of bone fractures. That would be something a little bit more unique to myeloma. So upon lab assessment, hopefully you can see the sheer importance of a complete blood count or a CBC, because we've talked over and over again, pancytopenia equals a low red blood cell, low platelets, and a low white blood cell. So we would expect in these blood type cancers and in anybody who has bone marrow suppression where these cells are made to have anemia, thrombocytopenia, and neutropenia, which is low neutrophils, or leukopenia, which is the total low white blood cells. So either way, decreased white blood cells. So decreased red blood cells, decreased hemoglobin, decreased platelets, and again, the white blood cells are the ones that's kind of could be normal, increased, or decreased, but in many cases, treatment of cancer with chemo and radiation will lower the white blood cell, and if they do have an increased number of total white blood cells, they actually have an increased number of immature white blood cells, so they still look like to be clinically immunosuppressed. So that's where the white blood cell, it's just not black and white, but just know that if the white blood cells are normal or elevated, to then take a closer look at the number of mature white blood cells versus immature white blood cells. Coagulation status, we do know that especially if there is metastasis to the liver, that there can be increased clotting times because the liver is responsible for making a lot of our clotting factors. So the slide says increased or decreased PT and PTT, but typically they will have a prolonged or increased PT and PTT, indicating that they have a higher risk of bleeding. They can do chromosomal or genetic testing for patients and families, especially for those cancers that do have a significant genetic predisposition. CMP, that's a complete metabolic panel. That's where you see all of your electrolytes and your kidney function, which is always important for everybody for every single condition, but especially elevated calcium you're looking at with multiple myeloma. LFTs are liver function tests, and again, if we have metastasis to the liver, which is a common organ for metastasis, liver function tests would be elevated, the numbers would be elevated, meaning the liver is declining in function. ESR, erythrocyte sedimentation rate, this is your increased with inflammation, so that may be possible as well. They can do various imaging, of course, chest, CT scans, PET scans. All of that is going to be very helpful for noting any nodules, tumors, etc. And then can show the progression if those are getting smaller, especially if they're doing radiation, chemo, etc. They'll use those scans as a marker for treatment progress as well. And then bottom line, the tissue biopsy is the only way that they can truly confirm the diagnosis. So they'll do a biopsy of the bone marrow, which we discussed earlier, and then they can also do those sentinel node biopsies of the lymph node and send those to pathology as well. I have just some of the tumor markers listed here on this page. Again, uses of the tumor markers can be, it's not the only thing they're using for diagnosis, but they can be used as a part of the diagnostic tool. Again, we need a biopsy ultimately, but those can be helpful. They definitely can help with as a prognosis indicator, and then we see them used for monitoring progress of treatment with chemo, radiation, surgery, etc. So CEA is carcinoembryonic antigen, and this is normally found in the colon. So you would expect this to be increased with colorectal, but also can be increased with other forms of cancer, as you can see. That is one that is not specific necessarily to one said location. Whereas the other ones you can see all have identifier. Those proteins are seen in a specific type of cancer. So again, you don't have to memorize these, but if we're working in oncology or we see any of these tumor markers listed in the stem of a question, we at least would recognize that this is kind of measuring how many tumor cells, and it's a prognosis indicator or a treatment monitor. So treatment goals and management of cancer is really about the cure, control, and palliation. So cure is basically what we ideally want, right? We want total eradication of any malignant cells and tissue that is carrying that cancerous cell. So ultimately before we have spread or metastasis. So curing can be possible, especially if it's caught early, and if it's all contained to that area of location, they can typically remove that area and have a good margin of safety around that is clear of any malignant cells. Control would be just to prolong the survival, again contain the cancer cells, maybe do debulking. That might help with removal of some of the cancerous tissue. That could help with comfort. And then palliation would just be more of that comfort cares, end of life, hospice, where we really are looking at just relief of symptoms that might be associated with that cancer. Throughout all of cancer care, it is really important for the RN to have open communication, education, and support to the family. We are the patient's advocate. We are the family's advocate. This is a very difficult time for people, and so that support is just absolutely critical. Again, cancer isn't necessarily a death sentence. I mean, nobody likes to hear the word "you have cancer," but again, until we know more, until we know what the treatment plan would be and how that's going to look for each individual, we just have to be supportive and let the doctors kind of explain more of those details of their options, what some of the statistics are, because we do have a lot of good research. There's a lot of statistical data on prognosis by year, number of years after certain types of diagnoses, which again is some of the information that families really want to hear and want to know. There's a lot of fear of the unknown otherwise. So we'll do our best. We'll collaborate with other members of the team, especially dietary and nutrition for our patients with cancer, undergoing cancer treatment and undergoing chemoradiation where they could have nausea, vomiting, anorexia, and things that we really want their nutrition to stay intact. Also, spiritual support would be another real common consult. I mean, of the two, pastoral care and dietary would be really the two most common for this area of nursing. Next, we will talk about some of the options for cancer treatment, whether that be surgery, radiation, chemo, bone marrow transplant, or a combination of the above. It really depends on the stage and the grade, the type of cancer, the patient's wishes, if there's metastasis or not. There's a lot that goes into developing an appropriate treatment plan and an individualized treatment plan for each patient. For surgical treatment, of course, it would be ideal to be the primary treatment, especially if that type of cancer tumor tissue is all contained. We could do complete removal of the tumor or of the organ in which all of the cancerous cells are contained, like removal of the bladder, removal of the ovary, cervix, etc. We can also do what's called debulking, which is removal as much of the cancer cells as we can. So for example, if cancer was in the ovary or maybe in part of the bowel, but then also was on the walls of the peritoneum, we can't take out the peritoneum. So they would debulk down all the way to like a millimeter, as low as they could get it all trimmed down. And then they'll usually do chemo after that to hopefully to remove the rest of those cells that are sitting there. That would be the best that they can do. So debulking can be for comfort, but it also could be get as much out as you can and then follow it with like chemo or radiation. Diagnostic surgery, so breast biopsies, for example, sentinel node biopsies where we're looking at that closest node I was telling you about. Again, we know that there has to be a margin of normal tissue removed as well, and any adjacent organs, limbs, and tissues where there is high risk of spread, they will usually remove a good margin of those as well. Radical cystectomy is the example here with a urinary diversion, and this would be where they removed the bladder, but then they also removed other organs right around that bladder, and then created a new urinary diversion stoma for a urine collection bag. Prophylactic surgery is not necessarily as common, but this would be where they're removing the non-vital tissues or organs that are very likely to develop cancers. So we see it more commonly with mastectomies. If I was diagnosed with breast cancer of my left, there's a very high percentage that I would also get at some point in time, maybe not till years down the road, but that I would get cancer of the right breast. And so some women are opting to just do a bilateral mastectomy at the same time. We see it more commonly with like reproductive, like hysterectomies and things, where they'll do kind of those reproductive removal of the organs that are likely going to develop cancers. Again, there's a lot of mixed literature on that because then they would need to have hormone replacement. I mean, there's goods and bads of everything, but those would be a couple of the examples that might be more common. Palliative surgery is definitely one in which they're focusing more on comfort. So they're doing surgery to relieve as much of the tumor as they can, for example, to relieve a bowel obstruction. That would be a very common, or a debulking to get as much of that tissue out as they can. That will help with the compression of that larger tumor on other surrounding organs, or in this case can cut off, can obstruct the bowel altogether and cause obstructions. So all of that is really dependent and defined by the patient and the family. What is comfortable for them? What does comfort mean? What would quality of life look like? Is going through a major surgery helping with quality or not helping with quality? Again, these are all decisions that will be discussed and made by the patient and their family. Reconstructive surgery then may follow curative or any radical surgeries. So again, if they've done major surgeries of the head and neck, there might be reconstructive cosmetic surgery there. Certainly with breast cancers, there might be reconstructive surgeries for implants. I know that they now have the availability, at least in some places, where if they did do a mastectomy, they could immediately at the same time have implantation done so that they don't have to have a second surgery. So I know they're not doing that everywhere, but there are different options out there for either immediate reconstructive or reconstructive surgery at a later date and time. Nursing interventions for cancer surgery are really going to be all about the emotional support, the advocacy. A lot of the other stuff is going to be the same. We want pain management to be a priority. We want nutrition to be a priority. We want to prevent post-op complications, teach leg exercises, teach the use of the incentiverometer, early ambulation. All of those things are same no matter what surgery they've had. But as far as cancer surgery, I would say definitely more the education, emotional support, advocacy, and giving them more of the resources and connectedness to cancer care and cancer websites would be more, of a priority for this particular patient. Radiation therapy is used for many types of cancers and possibly as a supplemental form of cancer treatment, even with surgery and or with chemotherapy. So ionized radiation is used to interrupt that cell growth. It causes breaks in the DNA strands or cell lysis, thus inhibiting the ability of that cancer cell to further divide and spread. So more than 50% of patients with cancer will receive some form of radiation during their course of treatment. So while everybody with cancer doesn't necessarily receive radiation therapy, a lot of people do. We also know that the radiation therapy team is comprised of an RN as well. So if you really enjoy cancer care, this might be a specialized area that you could work. There is a radiation physicist who makes sure the equipment is working properly and delivers the correct dose. There's the radiation oncologist who prescribes the type and amount of radiation. And then there's the registered nurse that works in that area that does a lot of the education, assessment of labs, teaching to their patients, families, fielding phone calls for side effects, complications, etc. And then, of course, there's the techs that work in the radiation department that help with the actual equipment and moving of patients, etc. Several of the indications for radiation therapy are listed. Preoperatively, there's a chance that they would have radiation first, just to shrink the tumor initially and decrease chance of metastasis, so that it may be a possibility. We know that there is the possibility of intraoperative radiation in hopes to get all of the tumor out, that once the body cavity is open, maybe they've done some debulking or surgical excision, but now they want to actually apply direct radiation to that area before they would close the patient. Postoperatively is definitely most common, where they would, if they don't get a clear margin, and even in some high-risk individuals or younger patients that have gotten a clear margin, they might do it still as a preventative measure to prevent reoccurrence. In conjunction with, before, during, or with chemotherapy is very common. And then it's largely used most entirely or solely for early stage Hodgkin's lymphoma. So again, they'll follow their radiation with a short course of chemo, 2 to 4 months or so, but that is the best treatment for Hodgkin's is radiation therapy. So many of you are probably most familiar with external radiation. This is the most common. Again, this is where it's delivered externally via what we think of like a machine, an X-ray type machine that transfers those electron beams or gamma rays. Again, the patient is not radioactive. They're getting their external radiation, again, a certain dose for a certain time that's individualized for each patient and each type and area of cancer. Internal radiation we call brachytherapy, and this is where the radioactive isotopes are delivered to the body fluids or in a sealed form. So we have radioactive seed implants, for example, for prostate cancer, and these will be implanted close to the tumor so that they can provide that direct radiation to that tumor in a much more close proximity rather than having to go through all of the body and other organs. Because again, remember, if we do radiation, let's say we're doing radiation of my neck for tonsil cancer, that's also affecting other areas and killing other healthy cells of that area. So this internal radiation will help to reduce the negative effects of radiation therapy on healthy cells that would be around that area. The radiation source is within the patient, so the patient will emit radiation and is a hazard to others, but we will talk about the specifics for caring for patients that have internal brachytherapy and for what their family members need to know. So this just shows a picture of what would look like for the radiation. They typically have a tattoo, something placed so that they know exactly the positioning. They leave it on the skin so that they have that available to know for that marking of where their patient's going to be positioned very precisely. We'll talk about some of the other radiation kind of just good to know things that will kind of help with some of the side effects as far as avoiding creams and lotions, or only use the ones that are prescribed by the facility. You know, we don't want anything with scents and a lot of other chemicals. They want to just use warm water to wash themselves. They want to assess for redness, cracking. They may have looks like a sunburn. Cotton clothing, non-itchy, not scratchy. Again, no sun exposure, super important. No hot packs, no cold packs, no extreme temps, no tapes, nothing on that area of the skin. We need to really protect that skin area from opening up, and it is pretty high risk for that and can have some what looks like the worst sunburn ever. So we need to really be helpful to them with what is going to come in contact with that area of the skin, whether it's their clothing materials or other chemicals, soaps, lotions, etc. So there are 3 basic principles for radiation safety: time, distance, and shielding. So this slide goes through the nursing interventions for a patient with a sealed implant. So for example, the radioactive seed implant or the brachytherapy that we talked about for somebody with prostate cancer. So they will be in a private room, or if they are cohabitating, the other patient also has to have a sealed implant. We will have a sign on the door and signage on the door that room room also needs to be fully scanned once the patient is discharged. Nurse protection, again, it's time, distance, and shielding. So lead aprons, and again, you see this in radiation too, in x-ray, and just regular radiation safety. If somebody is working in radiation therapy, those techs and things will wear a dosimeter badge, and that measures their amount of exposure over time. Shouldn't be an issue for us as nurses on the floor, but we want to limit exposure to approximately 10 minutes every 2 hours or 30 minutes per shift. Again, this isn't precise. This doesn't have to be exact. I mean, 30 minutes per shift doesn't sound like a lot, but we want to definitely consolidate our cares. Make sure when we go in the room, we're doing what we need to do. We're giving quality care still, but we're not spending a lot of excess time in the room. We are definitely not going to touch the radiation source with our bare hands. So if for some reason we see it looks like it might look like a little metal like seed, we would use a forceps and we place that in the lead container that we keep in the room. If any of those are dislodged, if they, again, with it being a radioactive seed implant for the prostate, most likely we would have those come out in the urine. No linen, waste, or anything is removed until that room is fully cleared. They'll go in with a wand, and nuclear medicine will totally clear that room and scan it for any radioactive things that might be present in the room. Again, time and distance is also, and shielding are the three things. So limiting visitors, again, we talked about our 30 minutes max, and even if I'm in the room, they say approximately 6 feet from the patient. No pregnant visitors, no visitors under the age of 16. Again, this kind of depends on the facility policy. If they have an implant in and around the genitourinary and reproductive area, typically they'll be straining urine, and if any comes out in the urine, then we would use forceps. We will not touch it with our hands and place that in the lead. We call it the lead pig, but the lead container that will be in the room. So the side effects of radiation therapy are really, really important. It's very important to understand if somebody is undergoing radiation therapy, what sorts of things are they most likely going to experience for side effects? And then to the next step, what can the nurse do about that? What can the nurse educate them about? What can they teach their patients to do to prevent more serious complications from their side effects? So I encourage you, as you're looking at these lists of side effects, to think about what would the nurse do? What are some priority or appropriate nursing interventions, for example, for fatigue and malaise, for anorexia, for nausea, for vomiting, and just not stare at this list of side effects, but to think what you're going to do with that information. So some of the GI, anorexia, nausea, vomiting, diarrhea are pretty straightforward. We're going to do what we can to offer small, more frequent meals, try to get them things that they like. Again, maybe antidiarrheals might be appropriate depending on the significance. Skin changes, skin irritation is really the most probable and can be the most significant. Again, that redness or erythema, they can look like a real bad burn. They can have blisters. So all of that is really, really important to be watching for. And it may not be immediate. It may come in 3 to 4 weeks, or 3 to 4 weeks after starting radiation. So we need to be watching for it from the start to the finish and be expecting that there's going to be some serious skin alterations someplace during their course of radiation therapy. Alopecia is where they're going to lose their hair, and again, if radiation site is the head, this is most certainly going to happen. So again, body image, making sure to get them resources for wigs, etc., if they choose. Low platelets, low white blood cells, again, risk of bleeding, risk for infection, so we'll do all of our teaching related to that. Alteration of the oral mucosa, again, if the radiation is more towards the head and neck area, we would expect them to have very dry mouth, a reduction in saliva, reduction in taste buds, and even after they're done with radiation therapy, they end up with a permanent lack of saliva, permanent lack of taste as what was before the radiation therapy. Again, they're cancer-free now, hopefully, but they typically have to live with the rest of those side effects forever. So that's not just during the actual course of therapy. Stomatitis is where they can get the redness, the sores, the inflammation, and all of that bad stuff actually in the mouth itself. So if that's the case, we're going to reduce acidity, of course. They will maybe have swish and swallows. Again, it's not necessarily yeast, but they definitely would have just salt water or warm mouth rinses would be helpful. And again, changes in taste. I mean, some of the side effects do depend on what the location of the radiation was, but these are some of the common things that we want to be watching for and that we would want to educate our patients about. This slide pretty much follows up with the last slide in what nursing interventions we would be looking at doing for our patients that might be at risk for or have actual impaired skin integrity. So this is focusing on the skin itself. Hopefully you can see all the things are pretty obvious. We didn't talk about no jewelry, but that would be very helpful, or at least minimized. No, because that's rubbing like on their chest and stuff, especially if that's the location of where the radiation therapy was. No adhesives, tapes, band-aids, any of that kind of stuff can be very tough on already fragile skin. No hot tubs, whirlpools. We talked about no direct sunlight. They don't want any chemicals that would be in perfumes, deodorants, aftershaves, and all that. So it would have to be all naturalistic type products. And they do have lists of all of these nice things for recommended lotion, soaps, and things like that at radiation therapy, which we can give to our patients.